Hello, 405. Welcome to Lab 10, Exercise Prescription for Special Populations. For today's lab, the objective is to learn how to utilize the ACSM guidelines to prescribe physical activity for individuals with cardiovascular disease, pulmonary diseases, obesity, and overweight. I also want you to apply the things that you learn from this lab to your prescriptions that you do for each other, for your lab partner. So if any of the prescriptions that we go over today apply to you, please go ahead and use them as guidelines and as inspiration to create your recommendations for physical activity. We're also going to be working on your lab project this week. So this is the overview of the physical, the health-related and skill-related fitness tests that we've done throughout the semester, right? So now that we were able to perform all the exercise tests, now that we were able to use the reference tables and rate our lab partners, our clients' level of fitness for all these parameters for cardiovascular fitness, muscular fitness, and skill-related fitness like balance, stability, agility, speed, reaction time. Now that we have all those tests performed and we have the ratings, now we can take a look at those, see what the strengths are, what their weaknesses are of my client, and use those to create my exercise program. So this is an overview of what we learned last week. That exercise prescription is the process of designing a regimen of physical activity in a systematic and individualized manner. So the plan ideally should follow all the following, right? Cardiovascular fitness, muscular fitness, flexibility, neuromotor fitness, and body composition. And for your final lab project, because it's fairly short, we're only going to be focusing on 3: cardiovascular fitness, muscular fitness, and body composition. But ideally, for all your clients, you want to include all those parameters. So the goal is to review the exercise prescription guidelines for individuals with metabolic and cardiovascular disease risk factors. So please note that for chronic diseases and health conditions, information is lacking. Thus, the guidelines and recommendations for apparently healthy individuals may be used and adapted, right? So let's say you have a client that they present a specific health condition and the ACSM guidelines don't provide to use very specific guidelines. You can use the exercise recommendations for apparently healthy individuals for that client, but with a very good clinical judgment, right? Make sure that you're making the right adjustments on the exercise program based on the individual that you're working with, specific with their health condition. It might be an injury, it might be a metabolic disease, right? Or any other chronic diseases. So you can adapt the ACSM guidelines to that specific client. And when you're always in doubt, right, you can always refer them to another professional in the field, maybe a cardiologist or an exercise physiologist, or you can refer them to their medical professional so that they can get medical clearance, cleared, and then referred to the appropriate professional for them to start their exercise program. So the exercise prescription guidelines and recommendations are presented using the FIT principle, like we've seen before: frequency, intensity, time, and type. So these are the exercise prescriptions for special populations. We're going to be focusing on the main following: cardiac diseases, for individuals with coronary artery disease and hypertension, for pulmonary diseases like asthma, and overweight and obesity. So these are the manifestations of cardiovascular disease and pulmonary disease. So as definition, cardiovascular disease These are diseases that involve the heart and or the blood vessels. It includes, but it's not limited to, hypertension, coronary heart disease, heart failure, right? And all the following. So these are all the lists. Acute coronary syndrome, myocardial ischemia, myocardial infarction, all those fall in the umbrella of cardiovascular disease. In regards to pulmonary diseases, these are diseases that involve the lungs, including but not limited to chronic obstructive pulmonary disease, COPD, and asthma. So we're going to talk about these main two. All right, for exercise prescription for individuals with cardiovascular disease, cardiac rehabilitation, abbreviated as CR, is commonly used to deliver exercise and lifestyle interventions. So the main purpose is for it to be an intervention designed to reduce the risk, foster healthy behaviors and compliance to these behaviors, reduce disability, and promote an active lifestyle. Right, so that's cardiac rehabilitation. And patients should be risk stratified as early as possible following their acute cardiac event or procedure in preparation for the initiation and progression of physical activity. Right, so I like this diagram. It summarizes what cardiac rehabilitation is, right? It's for it to lower the chance of a second heart attack or heart surgery, that is most common, to reduce the overall risk of dying or having a future cardiac event, also lessen chest pain, help with weight loss if needed, and control risk factors of high blood pressure and cholesterol. So the thing that you might encounter and most common. And I just wanted to go over this briefly again. We went over this, we learned this in our lab 1. These are the cardiovascular disease risk factors and defining criteria. So these are things that you want to be aware of before initiating the exercise program, right? You should go over these lists and this stratification while you're performing the Part Q, maybe an informed consent, a medical health history, and you're establishing their level of fitness. You are also establishing how many risk factors your client may have, right? So this is table 2.2, the ACSM 11th edition, cardiovascular disease risk factors and defining criteria. So if your client presents any of these risk factors on this first table, right, they're at a higher risk for a cardiovascular disease. So if they have past family history of myocardial infarction, right, if they're cigarette smokers, if they don't meet the minimum threshold of physical activity, if they have a body mass greater than 30, right, if they have high blood pressure, their lipids and blood glucose, all these, if they present them, they're at a higher risk for CVD, right? So this is a good thing to perform before you start working with a client, so you can, 1, develop the exercise program, right? 2, you educate your client about their risk for cardiovascular disease, right? And you can have that conversation with them and help them understand, make sure that they can perform a modification on their lifestyle. So this is the risk stratification, right? For cardiovascular disease, things that we want to take into account, things that are important to go over before initiating the program. All right, but your client has cardiovascular disease, right? So the American College of Sports Medicine has adopted the risk stratification system established by the American Association of Cardiovascular and Pulmonary Rehabilitation for outpatients with known cardiovascular disease. So the ACSM put this together to stratify patients with cardiovascular disease if they are ready for an outpatient cardiac rehabilitation. So if they don't present any chest pain in the previous 8 hours, right, and then they meet this following criteria, then they can follow an inpatient cardiac rehabilitation. So these are the indications and contraindications for cardiac rehabilitation. Basically meaning whether they're ready and they can be a part of cardiac rehabilitation or not. So some indications, right, like I mentioned, stable chest pain, medically stable post-myocardial infarction, and all the following, then it can start a cardiac rehabilitation program. These are some contraindications: unstable angina, chest pain, right, or uncontrolled hypertension, resting systolic blood pressure over 180, and or resting diastolic blood pressure over 110. We're going to go over some recommendations for exercise prescription for individuals with hypertension. So just take note that if they do have uncontrolled hypertension, then they might be, with good clinical judgment, you may modify the exercise prescription for resistance training, cardiovascular training, or flexibility. So just a thing to take a note of. And I like this diagram too. These are core components of cardiac rehabilitation, right? And it doesn't involve just the physical activity counseling and exercise training, right? It involves all of the following: patient assessment, nutrition counseling, weight management, blood pressure management, lipid management, diabetes management, tobacco cessation, psychological management, to make this cardiac rehabilitation holistic, right? We're taking an overall holistic approach, targeting it from all different parameters so we can ensure the health and fitness of our client. All right. So this exercise prescription for cardiovascular disease, usually you'll perform a graded exercise test on your client, right? And determine the current condition of their cardiovascular disease and study the function of the heart, the electrical activity of the heart, but this might not always be possible. So a graded exercise test may invoke monetary costs to the patient in the form of meeting insurance plans, deductibles, and copays. Thus, ordering physician or mid-level provider may request that a patient participate in outpatient cardiac rehabilitation without an exercise test, right? Because it might be expensive, might not be possible for your client to perform, so they can participate in outpatient CR. So the following section on exercise prescription provides methodology for guiding exercise intensity when results from an exercise test are not available. So these are your ACSM recommendations using the FIT principle for individuals with cardiovascular disease, participating in outpatient cardiac rehabilitation. I know this table looks a little different, right? It's in purple and gray, but it's the exact same one as the one that you have on your lab manual. This is just taken from the 10th edition. That's very, very similar. It's the same as the 11th edition. So it's split into 3 parts: your FIT principle for aerobic, resistance training, and flexibility training. So the ACSM recommends that individuals participate in aerobic training minimally 3 days, preferably 5 days or more per week. The intensity with an exercise test, usually you can start them at 40% to 80% of their exercise capacity, right? You can use the heart rate reserve, VO2 reserve, or VO2 peak. But without a graded exercise test, you can use a seated or standing heart rate at rest plus 20 to 30 beats per minute. This is just a basic formula that you can use for your client if you weren't able to perform that graded exercise test, right? Or you can go prescribe intensity using the RPE scale on 12 to 16 on the scale of 6 to 20. Time 20 to 60 minutes, and type any type of ergometer, right, for the upper or lower body. For resistance training, 2 to 3 days per week that are non-consecutive. Perform 10 to 15 repetitions of each exercise without significant fatigue on the RPE scale 11 to 13. 40 to 60% of the 1 rep max, right? So very low intensity overall compared to other types of resistance training where the intensity might be a little bit higher. 1 to 3 sets, 8 to 10 different exercises, selecting equipment that is safe and controllable for the patient to use. And flexibility is 2 to 3 days per week to the point of feeling tightness or slight discomfort. Time, 15-second holds for static stretching, 4 repetitions of each exercise, and performing static and dynamic stretching, focusing on the major joints and limbs and the lower back. And you can even perform PNS stretching. Now let's talk about hypertension. Chronic primary essential hypertension is defined as resting systolic blood pressure of over 140 and resting diastolic blood pressure over 90, or taking antihypertensive medication for the purpose of blood pressure control. These are your blood pressure categories. Although hypertension is not an indication for exercise testing, meaning that even though my client might have high blood pressure, I don't need and I don't require from my client to perform an exercise test, right? This is not an indication for exercise testing, but the test may be useful to evaluate the blood pressure response to exercise. And this was something that we learned previously in the semester when we were working on the cycloergometers. You were exercising at a specific percentage of your heart rate max, and we were studying the blood pressure response during that bout of exercise cycling on the bike. I don't know if you remember, you were doing manual blood pressure, right? That was fun. We were able to study the blood pressure response during exercise. So if a client has hypertension, right, and their high blood pressure maybe is not controllable, you might find an abnormal blood pressure response during exercise, right? So this is something that we just have to be very mindful about, and we should just take precaution on when we are prescribing exercise and exercise intensity. So individuals with hypertension may have an exaggerated blood pressure response to exercise, right? Even if resting blood pressure is controlled. So you might see that, the normal blood pressure response as exercise intensity increases is not normal, right? It might be abnormal. So you have to be mindful. Prehypertension may also have a very similar response, right? So again, just take note to be mindful of these things. So exercise testing recommendations vary depending on their blood pressure level and the presence of other cardiovascular disease risk factors, right? The ones that we just previously talked about that target organ disease or clinical CVD. So here are your ACSM fit recommendations for individuals with hypertension. For aerobic training, 5 to 7 days per week. Start them at moderate intensity from 40% to 59% of the VO2 reserve or heart rate reserve, or on the RPE scale 12 to 13. Time, 30 minutes per day of continuous or accumulated exercise. If intermittent exercise is performed, begin with a minimum of 10-minute bouts, right? So if they can't handle the 30-minute bout session straight, then you can chunk it up into different parts, 10 minutes and 10 minutes after 10 minutes, right? With a little bit of rest in between, or different days. And perform aerobic activity, like prolonged rhythmic activities using large muscle groups, like walking, cycling, swimming. For resistance training, 2 to 3 days per week, 60 to 70% of the 1 rep max, and progress to 80% of the 1 rep max. And if they're novice exercisers, you can begin at 40 to 50% of the 1 rep max. 2 to 4 sets, 8 to 12 reps, and using resistance training machines, free weights, and a body weight. And flexibility stays very similar, 2 to 3 days per week, stretch to the point of feeling tightness or slight discomfort. Hold the static stretch for 10 to 30 seconds, 2 to 4 repetitions for each exercise, and type static, dynamic, or PNF stretching. Now let's shift gears. Let's talk about pulmonary diseases. Chronic pulmonary diseases are significant causes of morbidity and mortality. And there is strong evidence that pulmonary rehabilitation improves exercise tolerance, reduces symptoms, and improves quality of life, right? So in a controlled setting, allowing my client to perform exercise, even with a pulmonary disease, is going to improve the quality of their life and reduce the symptoms. So there is scientific rationale that supports exercise training in people with non-COPD respiratory diseases like asthma, cystic fibrosis, and confirms similar benefits as those seen in COPD. For patients with COPD, evidence-based recommendations and clinical practice guidelines indicate that exercise training should be a mandatory component of pulmonary rehabilitation. Exercise medicine, right? Asthma is an heterogeneous chronic inflammatory disorder of the airways that is characterized by a history of episodes of bronchial hyperresponsiveness, variable airflow limitation, recurring wheeze, dyspnea, chest tightness, and coughing. So your exercise prescription for individuals with asthma, there is evidence for exercise training to be an effective therapy for asthma, but still very specific exercise recommendations are lacking, right? So this is where you will perform with good clinical judgment any modification on the ACSM recommendations for exercise training to your client, making sure that you're ensuring not only the safety of your client, the health, and improving their quality of life. Exercise-induced bronchoconstriction is defined as the airway narrowing that occurs because of exercise. So again, exercise might be very useful long-term to improve the quality of life of your client with pulmonary disease, but you also have to be very mindful at what intensity of exercise you start them at so you don't cause EIB, right? Exercise-induced bronchoconstriction. Asthma symptoms can be provoked or worsened by exercise, which may contribute to reduced participation in sport and physical activity, and ultimately to deconditioning and lower cardiorespiratory fitness. So again, be mindful of choosing the right intensity for your client. And for athletes, environmental triggers such as cold or dry air and air pollution, including in the particular matter, allergens and trichloramines in swimming pool areas may contribute a bout of EIB. So here are recommendations for individuals with asthma. For aerobic training, 3 to 5 days per week. Begin with moderate intensity, 40% to 59, and progress up to 60 to 70% after 1 month. Time progressively increase to at least 30 to 40 minutes per day, and any aerobic activities using large muscle groups. For resistance training, 2 to 3 days per week. For strength training, 60 to 70% of the 1 RM. For beginners, 80%. For experienced weight trainers. And for endurance training, anything less than 50% of the 1 RM. Strength training, 2 to 4 sets, 8 to 12 reps, or this could be adjusted, right, based on your the level of fitness of your client and on your clinical judgment. And using weight machines, free weights, body weight exercise, etc. And flexibility training, 2 to 3 days per week. Stretch to the point of feeling tightness, 10 to 30-second holds. That's using static, dynamic, or PNF stretching. All right, now let's talk about overweight and obesity. It is defined as a body mass index, BMI, of 25 to 29 and 30 kilograms per meter square or greater, respectively. For all ages and ethnicities, overweight and obesity are linked to an increased risk of the development of numerous chronic diseases, including cardiovascular disease, diabetes, some forms of cancer, and musculoskeletal problems. So the management of body weight is dependent on energy balance that is determined by energy intake and energy expenditure. So your best bet to improving their like current state and decrease the risk for obesity-related diseases is the lifestyle intervention for weight loss to combine both reductions in energy intake with increases in energy expenditure through exercise, or just overall minimizing sedentary activities. So a sustained weight loss of 3 to 5% is likely to result in clinically meaningful reductions in cardiovascular disease risk factors, including triglycerides, blood glucose, HbA1c levels, and the risk of developing type 2 diabetes. But due to low levels of fitness at the beginning for your client, it may be very difficult for them to perform a volume of physical activity required to achieve clinically significant, meaningful weight loss. So, combination of moderate reductions in energy intake, so their food intake, those dietary changes with adequate levels of physical activity is going to maximize their weight loss. And unfortunately, we don't have enough time throughout the semester to talk about nutrition, but this is something that you have to be aware of and potentially work with a dietitian so you can help your client with their weight loss, right? That is healthy in a systematic manner, right? And that is going to ensure that your client not only loses weight, but improves their overall quality of life and dietary behaviors. So the ACSM position stand on physical activity and weight loss concluded that less than 150 minutes per week of physical activity promotes very minimal weight loss. Over 150 minutes per week of physical activity results in modest weight loss of 2 to 3 kilograms per week. And up to 225 to 420 minutes per week of physical activity results in a more meaningful weight loss of 5 to 7.5 kilograms. So your best bet is to prescribe either the option B or option C, right? Obviously, with good clinical judgment, you'll see how much physical activity your client can tolerate and minimize their sedentary behaviors and increase their physical activity. So to promote long-term weight loss maintenance, right, progress to at least 250 minutes per week and prescribe moderate to vigorous exercise. And exercise and physical activity should be performed on 5 to 7 days per week, right? They might start at 1 day per week. You might start progressing them from there, and that's fine, right? As long as you don't overwhelm your client too much, you give them smart, specific, measurable, attainable goals that are realistic for them to perform and keep them accountable to, that's how you're going to find most success. So these are your fit recommendations for aerobic training. I will recommend 5 days or more days per week of training. Initial intensity 40 to 59 and progress to vigorous intensity over 60% for greater health benefits. Time 30 minutes per day or increase to 60 minutes per day or more. And again, this could be that programmed training, that exercise, and also minimizing sedentary activities like physical activity. And type prolonged rhythmic activities using large muscle groups. Resistance training 2 to 3 days per week, 60 to 70% of the 1 rep max and gradually increase from there. 2 to 4 sets, 8 to 12 reps, and using resistance machines and free weights. And for flexibility, 2 to 3 days per week, stretch to the point of tightness, hold a static stretch for 10 to 30 seconds, and performing any static dynamic or PNF stretching. So all of these recommendations, right, use them as inspiration to create your own recommendations for aerobic resistance training and flexibility for your lab partner. And also in the future, right, you have an introduction to what these recommendations are for these specific populations. If you're curious about other populations, go ahead and look at your ACSM 11th edition guidelines. They're awesome. They provide a lot of information on how to go about uh, exercise prescription, right, for different populations, and if you need medical clearance or not, or what to do in specific scenarios. So, yeah, if you're curious and want to read more about these populations, you can go ahead and look at your guidelines. So please, for your lab manual, you're only going to be submitting the manual, right? The results, and the discussion section, answer all the questions and the table where you'll be able to create your own fit recommendations for aerobic resistance training and flexibility training for your lab partner. And after that, you should be all set. You should have all the information you need to create your final lab project. So that'll be the last thing that I would ask you all to do, to take the results from lab 9, lab 10, and all the results from the exercise tests that you performed throughout the semester to start your project, that essay and your exercise program with all the specific exercises and recommendations that you make. And that is it. Thank you for listening. Thank you for an awesome semester, and I'll see you in the next one.